Welcome everybody to another edition of the Intellectual Calisthenics, and I am honored and privileged to have Dr. Sandip Raha from the UK. Very soon, Dr. Raha is going to introduce himself. He is a specialist in movement disorders and particularly in Parkinson's disease. And our topic today is Parkinson's disease. What I wish, so rather Dr. Raha wishes his patients knew more about. So over to you, Dr. Raha. Please, will you introduce yourself?
Hi, everybody. I'm Dr. Sandip Raha. I practice in UK in NHS Hospital. I'm a NHS Hospital consultant. And I'm originally a geriatrician, but I have been into movement disorder and particularly Parkinson's disease for the last 20 years. And I developed the Parkinson's disease service in my local hospital and a neighboring hospital as well. And I now exclusively do Parkinson's disease. I do 4 clinics a week, and I have got probably over 700-800 patients, which I manage in my database. Nice to be here with you, Dr. Shabnamkar.
Thank you, Dr. Raha. And I do understand that you are also helping out patients in India. It's like more of a charitable program that you are doing. I know you have helped a lot of them through, teleconsulting or what our usual WhatsApp network. So, and
yes,
I know that, yes. So will you tell our audience a little bit about the teleconsulting part of it? Because I'm sure many people are looking for Parkinson's disease specialists like you in India, and teleconsulting gives a very good access to many people.
Yes, nearly 5 years ago, once I retired from full-time employment and went back part-time employment and only doing Parkinson's disease, I did 2 years, twice a year, voluntary clinic in big corporate hospital in Kolkata. And in that hospital, they collected the Parkinson patient for me, and I saw them as an outpatient. And over 2 years, I had around about 50 patients with Parkinson I saw on different occasions. And subsequently, I'm doing some consultation now through WhatsApp and teleconsultation. Also, I'm a part of 2 global online health apps, and I do free sessions for question and answer on Parkinson for general population, and then also have then specific one-to-one consultation, particularly in WhatsApp, on patients' requests from their family, usually son or daughter, to do teleconsultation through WhatsApp. And I have got around about 20 patients I have been consulting like that in last 18 months.
Thank you, Dr. Raha. So how we will go about today's video is Dr. Raha is going to explain, number one, what is Parkinson's disease, and very briefly. And the second thing is, because most importantly, if you are someone who's listening to this video, you want to know, is that something that is affecting either myself or some loved one or some family member you're living with? Because you're wondering, I can see some changes. Is it Parkinson's? So that is number one. Number two is people who already have Parkinson's disease. What are the things they are most concerned about? That is going to be the second area. Third, because in the interest of time, we cannot do a deep dive into all the areas, though I think, Dr. Raha, we probably have a series. Third would be, what are the treatment options available? And Dr. Raha is very familiar with the treatment options available in India. Of course, UK, he is familiar. And what is the criteria on changing one type of treatment to another? And the next, if we have time, what are the other things other than the usual problems that we think of when someone with Parkinson's has a problem of movement? That is the main thing we used to think. So back in I'm by background, my training was as an OBGY. So as an undergraduate in India, we did not learn a lot about Parkinson's. And then if we have time, maybe we are going to go to some of the future of detection of Parkinson's disease and how the prodromal phases, if we can start intervening early. But I am not so sure we'll have time for everything, Dr. Raha. So first and foremost, what is Parkinson's disease and how common is it?
Parkinson's disease is a neurodegenerative condition that basically means, in layman's term, that the neurons which produce a specific chemical called dopamine in our brain, those neurons die. Now, degenerative means that as we're getting older, those neurons are dying. So a 20-year-old and a 70-year-old don't have same amount of those neurons producing the dopamine. And this particular dopamine chemical makes us agile, makes us react quickly, makes us more attentive and interested in life and surrounding. So you can imagine a 20-year-old's reflex and a 70-year-old's reflex. And that's to some extent due to age-related reduction in this dopamine level. Although Parkinson's disease is known for over 200 years now, first described by James Parkinson, and in Indian mythologies and shastras, Parkinson has been described from 6th or 7th century, as far as I know. But it has mainly been described as a motor problem. That means problem with movement, problem with shaking, problem with balance, problem with speech. But there are lots of non-motor symptoms, which has been realized in last 15 to 20 years. And they have got significant impact on patient and their carers' quality of life.
Thank you, Dr. Raha. So you talked about dopamine loss in Parkinson's disease. So first and foremost, what from my brief understanding is, by the time someone is diagnosed with Parkinson's disease, they have already lost about 70 to 80% of the dopamine producing cells in a particular part of the brain. Am I right about that?
It's we say around about 50 to 60%. It also depends on the age of the patient at diagnosis, because it's obviously diagnosed more frequently in older age group. And the reason being, the older age groups are losing the dopamine anyway from aging process. So any further deficiency is more obvious in older age group. And younger age group, people in their 30s, 40s, and 50s, have got a lot of reserve still of dopamine. So symptoms may not show up.
And
so it's around about 50 to 60%.
Okay,
yeah.
Sorry. Another important thing, Dr. Raha, is as far as I know, we don't yet know the specific cause for this dopamine loss, because not everyone who ages has Parkinson's.
Yeah.
So what are some of the possible, again, no one specific cause, but what are some of the possible relationships?
I mean, the dopamine loss, actual pathology in the brain, what we call synucleinopathy in scientific term, which basically means a protein which is broken down because the cells and neurons dying. And after the death of the cells and neurons, this synuclein, which is a foreign protein, is deposited in different parts of the brain. Now, young brain can manage some of the synuclein deposition, but older brain cannot. And that's the main problem, and depends on which part of the brain the synuclein is deposited, that you get the symptom. Some people with Parkinson have more synuclein pathology in basal ganglia, which is a part of the brain that deals with movement, motor, and alertness, coordination. And those people present with a movement problem, coordination problem, slowness. In other people, this synuclein pathology is more outside the basal ganglia, and they may present with depression, anxiety, lack of different types of sleep problems, and generally, slow and lethargic and rigid body. So these are different types of presentation, and the actual reason why these cells are dying more in patients with Parkinson's disease, That's a $1 million question that is not known yet. There are lots of research going on. We know the process of dying, but we don't know the exact why they die. There are lots of risk factors have been identified which can cause more Parkinson disease. One of the major risk factor, what we call REM sleep behavior disorder. And in layman's term, REM sleep behavior disorder means if you have a person who shouts, screams, thrashes in bed or falls out of bed repeatedly, they won't know about it, but their bed partner will know about it. That's a big risk factor for developing synucleinopathy, not Parkinson disease, but synucleinopathy, which means another few variants of Parkinson.
So basically, Dr. Raha, how does a diagnosis normally happen? And I know the health systems in UK and in countries like India are different. So in the UK, obviously the patient would probably first go to their primary healthcare practitioner, and much later on in their journey would they be referred to a specialist like you. Versus in countries like India, it's usually the relatives who suspect that something is not okay.
Yeah.
And what are some of the sort of like the red flags people can see in their loved ones or someone they know very well? What are the things that it should kind of tell them, you need to go to a neurologist to get screened for Parkinson's disease?
I will say more from Indian perspective,
Yes.
because in UK it's a very streamlined approach,
Mm.
and a nice guideline, which is
Yeah.
National Institute of Clinical Excellence in UK, says that anybody with suspected Parkinson should see a clinician who has got interest in Parkinson, not only a neurologist but interested in
Mm.
Parkinson. In India, I will suggest that for relatives or friends or co-workers, if they find things like asymmetrical tremor or shake, by that I mean one side of the body, like one hand or one leg, or one side of the body, hand and leg, shaking, particular shaking at rest, which is more suggestive of Parkinson type shakes. Parkinson shakes actually get better when you use your hand. So there are lots of other conditions which can cause tremor or shakes, but Parkinson's shakes typically get better when you use it and more so when you're resting.
Okay.
Patient may have a gait or walking problem as well, and these may happen over many months, doesn't happen overnight.
Hmm.
Those are the two main common way of knowing. And person's voice change, less interested, withdrawing from family interactions, sleep problem. I mentioned about RBD. So those are the pointers. I think if family members, friends, they see, they should try to convince the person to see a neurologist.
Yes, thank you, Dr. Raha. And again, another important factor is now I think we will have to talk a little bit about the prodromal stage of Parkinson's disease little later on, because I want to move on to, so first in terms of diagnosis, so someone thinks that, okay, my father, and this is interesting, this is probably one of those diseases because Alzheimer's, there are more women than men. But in Parkinson's, more men get affected than women. And I don't think we know exactly why. I don't think the research has yet figured out. So usually, okay, you are suspecting that maybe your father or uncle or someone in the family seems likely it is possible that they'd have Parkinson's. So that they go to a doctor. The next thing is the diagnosis of Parkinson's, Dr. Rahat, typically only clinical, or do they need to go through some imaging or other investigations as well?
I mean, so far, even in Western world, diagnosis is still clinical diagnosis. What we call UK brain brank criteria, which is still followed all over the world.
Mm-hmm.
The way this criteria was developed, that Parkinson patient donated their brain, and after their death, brain was looked at for this alpha-synucleinopathy, and particularly in basal ganglia, which is the motor center of the brain, and then compared with their symptoms in from their medical notes, what type of symptoms they had. So according to brain criteria, you have to have bradykinesia, which in layman terms means slowness of movement. And by slowness, I mean not general slowness, but decrement of movement. That means if you are doing a hand tapping like that, and one side slowly gets
Okay.
decrement, you know,
Oh,
not just
okay.
slow, but the amplitudes get smaller and smaller, and this side is continuing. So the one side is more affected. That's very important to know in Parkinson. Very rarely it will be affecting both sides at the same time. And walking also, the gait problem, that is called, this is due to rigidity. So bradykinesia is first, has to be present, and rigidity is the second component, which means one arm or one leg or maybe one whole side of the body will be more rigid than the other side. You always compare good side with the bad side. That's the way the diagnosis is done. And the third one is tremor. As I said, the tremor is usually rest tremor, and it's called typically pin rolling tremor, like you do, rolling a pin, at rest. So these three are brain criteria. You have to have at least two of them out of three, and bradykinesia is a must. You have to have bradykinesia. But over the years, things are moving in a slightly different direction, because as we are more aware, there are a lot of non-motor symptoms in Parkinson, higher risk factors symptoms in Parkinson, like I mentioned about sleep. Constipation is also very commonly seen, and people may have constipation even 5-10 years before their symptoms. And by constipation, I mean not opening your bowels even at least twice a week. You opening maybe once a week, or really struggling without any obvious reason. And lack of olfaction, loss of olfaction, that means sense of smell. Now, there are lots of causes of loss of sense of smell, particularly as we are going through a pandemic and getting over COVID. As you know, COVID can cause lack of sense of smell. But if it is continually there for over 2, 3, 5 years, or my patients say, I never actually had a good sense of smell.
Oh, wow.
Our patient will
Interesting.
say that, yes, I can smell everything. And their wife or partner will say, no, you can't. Remember that the other day the toast was burning and you couldn't actually smell it?
Oh,
So
wow.
that those are the pointers, that these are sort of additional, we call non-motor symptoms, which can direct towards the diagnosis. If you still got issues, there are some special scanning available, but unfortunately it's not available in India very widely. One is a radioisotope gamma scan of the basal ganglia. But normally in Indian scenario, I will say if I have got 2 out of 3 brain bank criteria with a chronic long-term history, and I am reasonably sure, I will give them a trial of treatment and see what the response is. Because the treatment, particularly treatment we give is levodopa, the response to levodopa is quite diagnostic in Parkinson's disease.
Thank you, Dr. Raha. So basically, when Dr. Raha says it's the diagnosis is essentially clinical, what is meant by clinical is based on only symptoms. For a diagnosis of Parkinson's disease, you don't necessarily need brain imaging or blood tests. But blood tests are necessary for other things, not for
Yeah.
like there is no one unique blood test which will tell you whether you have Parkinson's or you don't have Parkinson's. So before we go to the next section of what bothers people with Parkinson's the most, one quick question, Dr. Raha, is because there are a lot of people who have relatives who have Parkinson's. So how much of the genetic component is there when it comes to Parkinson's disease?
Very good question. I think the genetic component depends on what's the age of the patient. And younger the age, particularly if they're in their 30s or 40s, and they have got a very strong family history of somebody in their family, direct family, father, uncle, maternal or paternal uncle or brother or grandfather, they had Parkinson early onset, then the genetics is important. But genetics is not really whole story, because even if you have a gene abnormality and mutation, that may not be the full cause of Parkinson. There are some kindred genetic families in the world who have got Parkinson, and they run in terms of dozens of Parkinson over 3-4 generations, all young onset. So those kindreds are very rare. Most of my patients who are older generation in their 60s or 70s, around about 3 to 5% may have a genetic, I would say, predisposition, not actual cause. So I don't routinely do genetics till I find that they have got 2-3 members of the family got it. And the reason for doing a genetic test is to see if they have got a specific mutation. So today we may not be able to treat it, but in 10 years' time, we may have a genetic treatment available. So if we know the mutation, that this patient got mutation of these genes and the treatment is available, then I know where to approach.
Thank you, Dr. Raha. So basically what Dr. Raha is saying is, if you have a family member, your father or uncle who has Parkinson's disease, that does not necessarily mean you will get the disease as well, unless it has occurred in someone who's very young. So the very young Parkinson's is not a common thing. The most common one is much older people. And this is where today we probably won't have time to talk about epigenetics, because just because there is Parkinson's disease in your family, it does not mean that you will get it as well. There are a lot of things you can do, and particularly all these symptoms that Dr. Raha is talking about. So the next thing is, Dr. Raha, because people in India want to know more about what are the different treatment options available, and how do doctors usually decide that, okay, levodopa is not working anymore, what is the next medication I need to move into? Where does deep brain stimulation come into it? Because it's available in India now, and a lot of people are going through that, though it's very expensive.
Yes, I mean, the gold, gold line of the treatment still is levodopa in Parkinson's disease, even in Western world. Although levodopa is over 60-year-old drug, but it is still the best drug available. Anybody who has Parkinson's disease will need levodopa at some stage of their life. There was a vogue nearly 20 years ago in Western world trying to avoid levodopa and use other medication, which are a group of called dopamine agonist. Dopamine agonist means they are like dopamine, but they are not exactly dopamine chemically. And when it goes to the brain treats it as dopamine and uses it as dopamine. So like tricking the brain. So they do have a lot of side effects. And long-acting dopamine agonists now are available in India as well. They are a bit more expensive. Levodopa is the cheapest drug, but the problem with levodopa is, although it's the best drug, but it's a short-acting. It has to be taken at least 3 times a day, sometimes even 4 or 5 times a day. So that becomes a chore for patient or their family to try to take medication 4 or 5 times a day, particularly if you're working, if you're active and all that. So in terms of oral treatment, medication, levodopa, dopamine agonist, and there is also another group of drug called MAO-B inhibitor, which is basically an enzyme inhibitor which inhibits the degradation of dopamine in the brain. So whatever dopamine you are still producing, it stops it breaking down, so you have more effect from your own dopamine. And those group of drugs are also available in India in names of selegiline, rasazoline, and they are once a day drugs. So that's the advantage. They are once a day. Dopamine agonist is also once a day if you use the long acting one, but they are for mild symptoms, particularly rasazoline and selegiline. They are for mild symptom. If somebody is really impaired, struggling, particularly gait problem, then levodopa is the best drug to choose, even if they have to take 3-4 times a day. As the years go by, the combination of these drugs are given in different doses. Levodopa do have another problem. If you go very high dose of levodopa, more than 700-800 milligram a day, then you can develop this abnormal movement called dyskinesia, involuntary movement, which is side effect of levodopa. It can be treated by reducing the levodopa, adding a second drug like dopamine agonist or MAO inhibitor. And my practice is that I never actually try to cross more than 500-600 milligram of levodopa a day. And if the patient needs more treatment, then we add other drugs. They do have side effects as well. Levodopa is probably the cleanest one, although
Mm.
you have to take it 4 or 5 times a day. So that's the oral medication, those three groups. There are some another group of drug called a COMT inhibitor. Entacapone is one of them, but it only works with levodopa. So you have to give them together. And that is available in India as well, entacapone with levodopa. That prolongs the effect of levodopa. So if you have levodopa working 3 hours, 3.5 hours, 4 hours, it extends it by another half an hour. So
Okay.
you have a less wearing off or breakthrough symptoms. In terms of advanced treatment in India, in Western world, we have got quite a few advanced treatment. And one of them is a long-acting dopamine agonist patch we use, which
Okay.
goes through the skin, and it's once a day. It bypasses the stomach. And it has got its advantage by bypassing the stomach. We can talk about that a bit later on if we have time, why there is an advantage bypassing the stomach. And there is also another injectable drug called apomorphine. Now, apomorphine is not actually like morphine. People get very scared about morphine. And even my patient, the ones they hear about apomorphine, they said, "What? I'm not going on morphine."
Mhm.
But apomorphine is a different chemical than morphine, and it's not addictive, it's not a painkiller, it's not a controlled drug. So apomorphine, unfortunately, is only available in injectable form at the moment. So that means either as a pen, like insulin pen, or a continuous pump. Now, India, a couple of companies have recently marketed apomorphine infusion pumps, but I'm not totally up to date how widely it is used. It's fairly expensive drug. It has to be given continuously during waking hours from morning till bedtime. And there is a little needle which goes under the skin, connected with a tubing and a pump. And the pump delivers it continuously at a certain dose. There are side effects of apomorphine as well. And in India, last time I knew, the cost of apomorphine is round about, I think it's quite expensive. We are talking about nearly 1 lakh a year, and
Okay.
it's an ongoing cost.
Mhm.
So you have to talking about around probably 10,000, more than 1 lakh, 10,000 rupees a month we are
Mhm.
talking about. So, and it's not available widely because in Western world, apomorphine is supported by Parkinson nurse specialist.
Mhm.
There are lots of Parkinson nurse specialists in UK and USA. I don't know whether you've got them in Canada as well. But
I'm not so sure, but I'm sure they are
yeah,
there.
but they manage the patient on apomorphine infusion. They set it up, they train the patient, they train the family. You need a family member who is prepared to take on the responsibility. So that's apomorphine infusion. And the next advanced treatment is deep brain stimulation, as Dr. Kar mentioned. That deep brain stimulation is available in India. Is very quite expensive, and I think it varies between different parts of India how good they are and how expensive they are. I think South India is probably the best in terms of Hyderabad, Bangalore, and Mumbai as well. But in Eastern India, it's not that widely available, and there isn't a huge experience of DBS in Eastern India. Um, Now, DBS in India, I think can cost anything between 5 lakh to 15 lakh rupees for surgery, different centers. But the issue with the DBS in India is that you need to have a follow-up and
Mhm.
proper setting, proper monitoring. That's very important. The way DBS work is called deep brain stimulation. That means the microelectrodes are put into the basal ganglia and you know thalamus of the brain after MRI scanning and computer planning. And these microelectrodes go inside the brain and stay there and is connected from outside. A wire goes under the skin, comes near up on the top of the chest, and as a pacemaker, connected as a pacemaker box. And that can be modulated from outside with a remote control. You've got a rechargeable batteries these days, so you don't have to have the stimulator changed with a battery. The battery can be recharged from outside. So that's the deep brain stimulation, and stimulating the basal ganglia, the subthalamic nucleus, actually inhibits the abnormal movements.
Okay.
So deep brain stimulation works best for people who have got tremor, intractable tremor, which cannot be controlled by drugs. Also, patients who develop levodopa-induced dyskinesia, this fidgetiness moving
Mhm.
from levodopa, and that actually is very well treated by DBS. So you can give more levodopa, if needed,
Mhm.
without causing the dyskinesia. So those
Okay.
are the two group of patients who benefit most from DBS. But the parameters of DBS, the amplitude and the stimulation parameters, all those amount of voltage given, all those needs to be modulated and monitored for individual patient. They're very individual. So you need to have a center which is totally devoted and patient is able to be followed up in that center on a regular basis.
Dr. Raha, one quick question. So patients who have had DBS, so from what you are saying is they would need continuous care, and this modulation of the, of the DBS, can any of this be done remotely, or do the patients have to usually go to the center? Because in India, it's like you mentioned, there are some centers, and if a patient is, let us say, in Eastern India, they would have to go there, or can it be done remotely?
As far as I know, they cannot be done remotely because there is no remote control of the DBS
Mm,
modulation in terms of amplitude and frequency. It has to be done there face to face because the amplitude frequency is changed by a DBS gadget, which is
okay.
available at the tertiary center, and they do it through the gadget. It's
Mhm.
not done by physically by patient,
Okay.
and each patient is different. Depending on how they have responded, they may have to do several visits.
Okay.
Like patients I have probably over the years nearly 25 patients who are DBS. And the DBS center nearest to us is in Bristol, which is other side of Wales, and around about 50 miles from here. And they do the DBS insertion in general anesthetic. Patient stays under between 3 to 5 days. Then they come home, but the modulation of DBS programming is done later on. Patient goes back, and
Okay.
then they do the programming, and it may need 2 or 3 visits over a period of 2 3 months to do it, depending on patient's activity, how
Mm.
much active they are, what they're doing. All those things are very important and mainly done by the nurses, but they are DBS nurses, exclusively DBS trained nurses.
Trained nurses. Thank you. Because given the ongoing pandemic, I think this has become a challenge for a lot of people in India about, because they were not able to go and visit for this modulation. So now from treatment, the other important thing is we are going to run out of time. So Dr. Raha, what are some of the things that you wish your patients, the patients you've seen in India, you wish they knew? Because I always tell you, you are spoiled by NHS, so you have a really nice support system, which in India, most of that support system is not
Yeah.
available. The support system is relatives usually. So what are some of the things you wished a lot of the patients knew?
Here, anybody who is diagnosed Parkinson disease, they have to be properly counseled. They and their family have to be counseled. that is a lifelong disease. You have to, at the moment, there is no cure. You have to live with it. And if you stop treatment all the time, you are not going to feel any better. There will be fluctuations. Disease will progress. There is no treatment which can stop the progression of the disease, not that we know of yet. So they need lifelong follow-up, lifelong treatment, lifelong to be under a specialist who knows what they're doing, got interest in Parkinson. And the worst thing can happen that if you shop around, if you go and see half a dozen neurologists and start all over again every time, that's probably the worst thing can happen, because you can't blame the neurologist, because neurologist has got 10 minutes or 15 minutes with you to go through all the previous problems you had on treatment, without treatment, and the features of motor, non-motor, all those is going to be very difficult. But if you get to know one neurologist who has got interest in Parkinson, that's the best thing you can do. And you have to stick with that person as long as you have got faith and believe in that person. Uh, that's the most important message, I think, for any patients in India. And like I say to my patient when I do video consultation in India, that I usually set aside half an hour to 45 minutes.
Yes.
And I bring their family, I bring their husband, wife, son, or daughter. Like other day, last Friday, I had a consultation with a patient who has got fair amount of cognitive problem and developing dementia from Parkinson. I did examine the patient through video and talk to him, but then I said to his wife and his son, can you go in the other room? I want to discuss with you a little bit more about your husband and dad. And I said that he's coming to a stage where he is going to deteriorate. His mental health is going to deteriorate. So you have to be prepared for all that. We can treat it to some extent, but we can't stop it. So they have to be prepared and plan their life accordingly.
Thank you, Dr. Raha. You brought up something so important because, based on, again, I don't see Parkinson's patient regularly, but as a functional medicine doctor, I have often been asked, like, is there something more we can do? Because obviously, a lot of people are not really happy with, and it could be so many different reasons. And one of the things that I found is these were like patients who've had Parkinson's for many years, and they were going to specialists. Some of them were themselves physicians, but they had never had an assessment of their cognition, which now I come from outside the Parkinson's and neurology world, and I'm thinking, but that is a known factor. So that is again something I think sometimes patients have to sort of, advocate for themselves, or their relatives have to advocate for themselves. So testing for cognition, Dr. Raha, for a patient in India, it's like you said, in 15 minutes consultation, you cannot cover everything. So what could a friend or relative of someone with Parkinson's who thinks that there is a cognitive decline, how can they kind of advocate for themselves when they go to the doctor?
That's a very
Unless they're
good
meeting
question.
you.
No, very, very good question, to be honest. And in fact, I have got some special interest in cognition in Parkinson.
Yes, I think you got an award a few years ago on a paper.
Yeah, because the reason being that it's a late onset Parkinson I deal with mostly, and people in their 60s, 70s, and even 80s, when they develop Parkinson, I'm not worried about how their shakes will be and how slower they get. I'm more worried about their memory. And that's what I tell their family. We normally test routinely anybody who has Parkinson for 5 years or more. We routinely check their memory. Obviously, it's much easier when you do face-to-face because we do MOCA, Montreal Cognitive Assessment Test. But in India, I would suggest you can do online MOCA. It's available, and it's available in Indian language as well, in Hindi, Bengali.
Yes, I know.
But what I tend to do at the moment, that I ask basic question to the family members, and you need to ask short-term memory questions. I'm not interested whether they can remember what they used to do when they worked in the bank or shop or whatever. But I want to ask the patient family, does he remember what he has eaten for breakfast today? If you had a phone call yesterday, does he remember that phone conversation? So
Mm-hmm.
those sort of things, is common, which family can feed you back. And the earliest warning, other than memory, short-term memory impairment, is visual hallucinations.
Mm-hmm.
Now, visual hallucinations is extremely good marker of memory impairment coming.
Mm-hmm.
And if you have removed the offending agent like drugs, like dopamine agonist I mentioned, that can cause visual hallucinations, even if they have taken it
Dr.
for a
Raha,
long
I'm going to
time.
I'm going to interrupt you there. Will you explain what are visual hallucinations?
Yeah, visual hallucinations means seeing things in the room which is not there. That means most commonly my patients here in UK and also in India, I will say, see small children, small animals, insects, or something crawling on the wall, or mistaking a curtain as a human. And that
Mm-hmm.
happens mainly in darkened and shaded, situation, not in bright light. It
Mm-hmm.
far less in bright light. And they may actually have very realistic visual hallucination. They may actually try to go and pick up those things from the floor, or catch the insect from the floor. And sometimes they may feel also somebody standing behind them. We call it
Mm-hmm.
sense of presence. So those are warning sign of visual hallucinations. Obviously, you have to exclude any drug-induced problem. And the next warning sign is excessive daytime sleepiness. That means dozing on and off during the day. Whenever they're inactive, sitting down quietly, they doze off. And
Mm-hmm.
you can wake them up, but they doze off again. Sometimes patient will doze off even in the middle of conversation or middle of eating their breakfast or dinner. So those are warning signs that there is a cognitive impairment happening, because there is a scientific reason for it as well.
Mm-hmm.
Because cholinesterase, acetylcholine, is a chemical which makes us alert and awake and interested. And there is a huge deficiency of acetylcholine in the brain in Parkinson disease. Happens in Alzheimer's as well,
Mm-hmm.
but Parkinson disease more than Alzheimer's. And when your acetylcholine level falls, you get drowsy, you get hallucinations, you doze on and off. So treatment we give is to replace that acetylcholine from outside.
Thank you, Dr. Raha. So this daytime sleepiness, or this is again, all could this also be a feature of obstructive sleep apnea? So
Yeah.
how would they, other than doing a sleep study, is there a way to differentiate? Or because again, a sleep study is an expensive study in India. It's like,
Yeah, I mean, obstructive sleep apnea, you have to have the right body shape as well. Quite often, you have to have a short neck, overweight, and it will be reported by the partner, hopefully bed partner, about symptoms of
mm,
obstructive sleep apnea, snoring, stopping breathing in the middle of the sleep. So all those, I mean, clinically, we can't do sleep study even in
no.
UK very often, to be
Oh,
honest.
okay.
So it comes from the history of the bed partner.
Mm-hmm.
And obviously, patients with Parkinson, they don't have the same type of body habitus. Not all of them got short neck and overweight,
Mm.
you know. So so
Thank
you need to obviously ask about the sleep. Sleep is important. If I don't sleep in the night properly for a few nights, I'll be sleepy during the day. You
Yes.
know.
Thank you, Dr. Raha. So, moving forward, before I go on to, because as a functional medicine doctor, we are always looking at predictive, preventive things. Can I find out any red flags and start taking some action? But as we have had numerous conversations on WhatsApp about. So most of the things that we look at are lifestyle changes, which can help reduce the risk. But of course, there are no studies which have looked at multimodality treatment options and followed these patients for many years, because Parkinson's is not going to happen like, you have prodromal
Yeah.
symptoms today and tomorrow, like they're going to come up with full-blown Parkinson's. Another important point, Dr. Raha, you mentioned is a lot of patients, one thing you mentioned is about going shopping from one doctor to another. Another thing I think many of them sometimes don't understand or don't remember the doctor telling them is the lifelong treatment necessary. So the treatments are used for managing symptoms. They are not curative, at least not yet.
Yeah.
And I think, Dr. Raha, in your practice, you must have seen many patients who start the treatment and then they feel, okay, I'm better now, I should just stop. That is there for other diseases as well. So that is one, I think, major area that you brought up, which is extremely important. Now, next part of the next section of the video, it's going to be more of like futuristic stuff, but I think that is something that is very exciting. And I'm just going to share one slide because I feel that, you know, a picture is sometimes worth show is easier to explain on a picture than anything else. So this is one slide. I'm just going to sorry about that. Oh, sorry. That is the one. So this is one where, you know, we've been talking about the prodromal symptoms. So basically, prodromal symptoms, as Dr. Raha mentioned, is all the symptoms that are, you know, evident before a person is actually diagnosed with Parkinson's disease. Yeah. And as a functional medicine doctor, what we would like to do, but I can't, like I said, we don't have any studies to use a multimodality behavior. We would like to, you know, instead of this trajectory going down this way, we would like to start interfering here so that they go this way and not this way. So what are some of the sort of red flags that we've been talking about in the prodromal phase? So Dr. Raha, will you just explain, because many of these, this is from a scientific paper, so the terms are medical terms, but Dr. Raha, will you just explain some of these, because you have definitely seen all of them in your years of practice.
Yes, I mean, I can pick up, I can't see them properly because it's, I can enlarge it, okay. So it says non-predictive prodromal markers. We discussed about REM sleep behavior disorder. And REM sleep behavior disorder in terms of prodromal and trying to prevent it is difficult. At the moment, we don't know, but you can improve it by, you know, change of sleep patterns, sleep hygiene, as well as maybe melatonin. Depression, anxiety, we all know about that. It can be treated. That is certainly got significant prodromal risk for developing Parkinson, particularly resistant depression, anxiety. Constipation, we talked about. Hyposmia, we talked about. Erectile dysfunction, urinary dysfunction, we talked about, and somnolence. Now, orthostatic hypotension, making sure there is no drugs implicated causing that. That means orthostatic hypotension basically means your blood pressure drops when you stand up from a sitting or lying position. Normally, our blood pressure should go up when we stand up from a sitting or lying position. So it happens just opposite, which is due to autonomic dysfunction, which is also the same mechanism, probably the constipation. And mild cognitive changes, yes, could be mild motor symptoms. But one of the things, prodromal symptoms, as Shabnam is saying, I personally feel, this is anecdotal, from many patients who have been under my care for many years, that exercise is quite a good way of trying to prevent even the progression of Parkinson once you're diagnosed. Because only last week I saw a patient who is quite advanced Parkinson now, but he's still very active and mobile. He had Parkinson's disease for 28 years. And one of the main reasons he's still active and mobile and independent is that he's a health fanatic in terms of exercise, And he can still do dancing. And we were talking about his stuttering gait, and he said, I don't get my stuttering gait when I dance. I said, yes, that's very interesting observation. You mentioned science knows about it, can't really explain it yet, why. And so exercise has been shown, even in scientific study, that increases the dopamine secretion and dopamine level in the brain. So it is just an observation, because unfortunately we can't measure dopamine in the brain. There is no test we can do to measure dopamine, like a blood test or a scanning test. So it is an observation, but exercise and activity, I keep on telling my patient that even early diagnosis in early Parkinson, that's the way forward. Don't stop and think about your Parkinson. Do everything you want. You go holiday, you fly, you exercise, you bike, whatever you want to do, you do.
Thank you, Dr. Raha. That is a very important message about exercise, because I've seen sometimes, people, family members feel that, okay, my father or uncle has Parkinson's, so he has problems with movement and he's slow, so he should not be allowed to go out alone or for a walk,
Yeah,
because they want to
exactly.
protect him. But it is
Yeah,
actually working counter to that,
negative
because,
effect. Yeah.
yes. And is there any particular type of, like you mentioned, dancing, and is it, for example, tennis over walking, or any particular type of exercise which shows more benefits versus, now, of course, we always say the best exercise is the one you will do regularly. So if you don't like tennis, of course, you're not going to take up tennis. But is there any data showing that, tennis or dancing is better for people with Parkinson's versus something else?
I mean, dancing has got some data, but resistant exercise has been shown.
Okay.
Resistant exercise, if you do against resistance, that means also weight, weight, mild to moderate weight lifting and all that. That's and the other thing which has been shown is Tai Chi, because Tai Chi deals with balance.
Yes.
And coordination. So, and holding the balance and coordination in certain position of the body for a period. So that has been shown to be effective.
Thank you, Dr. Raha. So I'm just adding a few comments on what, as a functional medicine, we would look at. Now, we know that recently there have been a lot of papers about the impact of the gut microbiome on Parkinson's symptoms, particularly the non-motor symptoms. That has been, and we know that, food has the biggest impact on the gut microbiome. Now, while, it's very difficult to do some of the food studies because of various reasons, but one thing we know, like, for example, if a patient would come to us, let us say with constipation, we can see that there is probably early cognitive decline after ruling out all the obvious causes. And one more factor, I think Dr. Raha recently has been added, is diabetes. So blood glucose levels as one of the risk factors for Parkinson's progression. So if we find these things happening, or that inflammation levels are high, so neuroinflammation, inflammation of nerve cells. Now, in my world of food as medicine, we look at changing their food first, because food is one of the biggest areas of inflammation. So eating real food versus eating food-like substances, that is one area we focus on very, very, like we have like laser focus almost on that. And reducing inflammation from multiple areas. Dr. Raha, you brought up exercise. Exercise is one of the best ways to reduce inflammation. Another thing we keep talking about is reducing continuous sitting time, all the television time, all the time in sitting in cars. So reducing sitting time is, again, very important. Reducing inflammation is another important thing. So again, lifestyle changes can impact, number one, it can reduce the time when someone develops more symptoms, or even if they already have symptoms, it can help to a great extent. Like over the years now, I've come to this conclusion. Anyone asks me, is there something more to do, with this particular disease? I said, yes, there is no disease on earth that cannot be, cannot get better with better sleep, better food, better movement, stress reduction, all these different factors. So thank you so much, Dr. Raha, for your very valuable time. And I'm sure this information is going to be extremely helpful for people. So if anyone has to,
sorry, you mentioned about gut microbiome. That will be another session, because that's one of my other side interests in Parkinson. And there is lots of scientific evidence coming out now on gut microbes.
So thank you, Dr. Raha. And before we end, one more question, Dr. Raha, if anyone was to reach out to you, is email the best way? Then I'll add your email address at the bottom of the video.
Yeah, I think I will appreciate email. Yeah, that will be better. Yeah.
Yes, so they can reach
And
out to
from
you
email,
on.
we can make further contact. Okay.
Yes. And as you rightly mentioned, I think we're going to need a series on Parkinson's and gut microbiome. And there are so many other, different
Yeah.
areas we can look at. Thank you very much, Dr. Raha.
Okay. Thank you.
Thank
Thank
you.
you, Shabnam.